pleasure of introducing Dr. Emily Steinhagen, a colorectal surgeon from my home institution of University Hospitals Cleveland Medical Center, where she's an assistant professor of surgery at Case Western Reserve School of Medicine. She also has important roles as the associate program director for the general surgery residency. She's also the clerkship director for the third-year medical students during their clerkship. Today, she's talking to us about hereditary polyposis syndromes. She's got significant expertise in this area. After completing her medical degree at Mount Sinai, she did her general surgical residency also at Mount Sinai Medical Center. During her time there, she did a research fellowship at Memorial Sloan Kettering Cancer Center, where she developed this expertise she's going to share with us today. Following her training in general surgery residency, she completed her colorectal fellowship at the University of Chicago. She has significant publications and expertise on a variety of subjects, and she happens to be one of the most amazing teachers I have ever seen. So I'm really excited that she's here and she agreed to join us tonight. So please, everybody, welcome Dr. Steinhagen. Thank you.
Thank you. I'm like blushing and red now. That was really nice. I'm really happy to be here. I am quite passionate about this topic and I've had a long-term interest in it. If any of you share that and would like to further your interest, there are some great organizations specifically devoted to hereditary cancer syndromes that I'm happy to tell you about and get you set up with. I'm going to try to cover a lot of material. If it goes fast, please just jump in and interrupt, ask questions. Don't feel bad. You don't have to wait till the end. And I can't see the chat, as you know, so someone can either monitor the chat and interrupt for you, or you just shout out. We're going to get going. Maybe. All right, I have nothing to disclose. Our learning objectives for today. So list the common hereditary cancer syndromes and the associated genetic mutations. This is relatively high yield for all sorts of exams you're going to be taking this year and next. To describe screening recommendations for polyposis syndromes, including extracolonic manifestations, and to understand the role of genetic testing in surgical decision-making. So we're primarily going to focus on the adenomatous polyposis syndromes with a little bit at the end on some of the other syndromes. Adenomas are common. Somewhere between 1/4 and 60% of adults should have an adenoma on colonoscopy. And many patients have more than one. One of the important things to realize, and when you see a patient who's had a lot of colonoscopies over the course of their life, is if they say, oh yeah, I always have polyps, it might be worth figuring out just how many. The most frequent polyposis syndromes are FAP, Lynch syndrome, familial colorectal cancer type X, MYH-associated polyposis. We're going to just mention the newly described syndromes so that you've heard the words. And then there's patients who clearly have something but no clear syndrome. Inherited forms of colorectal cancer should be identified ideally before we operate on our patients so that patients can participate in early detection programs. In many cases, they're going to fall into a recognizable category, but there's a fair amount of overlap and it's not always obvious which diagnosis is appropriate based on phenotype. Depending on which textbook you read and when it was written and published, sometimes people are still referring to Lynch syndrome as HNPCC, which is incredibly confusing. That term came from before the time where we had genetic testing and could really identify who had Lynch syndrome versus who had a lot of polyps. FAP is an autosomal dominant mutation. It accounts for less than 1% of all colorectal cancers, and that number has decreased over time because now we take people's colons out. The mutation is in the adenomatous polyposis gene on chromosome 5q21. We've all heard of the APC gene. It's a tumor suppressor gene, just like sporadic adenomas come along that pathway, and sporadic cancers form along this pathway in about 80% of cases. One of the important things is that 25% of patients with FAP are de novo mutations, meaning no one else in the family will have a history suggestive of it. And if you scope their parents, they won't have it. Or if you do genetic testing on their parents, they won't have it. The APC gene is part of the WNT signaling pathway. It leads to aberrant transcription of c-Myc, cyclin D, and other molecules via the accumulation of beta-catenin. Probably the key words from that are cyclin D and beta-catenin in terms of testing. The APC gene also affects cell adhesion and microtubule assembly. There are a lot of different mutations that can lead to FAP, And not all mutations in a gene, as you know, are pathogenic. So just because you have a mutation doesn't necessarily mean you have the syndrome. The phenotype that you think of with FAP is hundreds to thousands of adenomatous polyps. It can be a range, however. Again, this is autosomal dominant. Untreated in a classical form of FAP, the median age for adenoma development is 17 years. The median age for development of colorectal cancer is 40 years, and the median age of death, if the patient is untreated, is 44 years. So that's pretty scary. Some of the more frequent extracolonic manifestations are fundic gland polyps, which are generally benign, almost hamartomatous histologically, polyps found in the stomach. Chirpy, which stands for congenital hyperpigmentation of the retinal pigmented epithelium. That is of no clinical significance, but sometimes families have this as part of their phenotype, and it can actually be used to screen family members. Very rarely an ophthalmologist will see this on exam and be like, oh, this is associated with colon polyps. However, a single spot is allowed. It's only when they have multiple spots that it's really suggestive of FAP. FAP patients may also have osteomas and fibromas, desmoid tumors, and then a variety of cancers, periampullary tumors being the second most frequent malignant tumor, medullomas, papillary thyroid cancer, and then hepatoblastoma, which affects very small children and infants. You can also think about FAP by phenotype. There are some correlations with genotype, which we'll talk about in a second. Attenuated FAP is less than 100 polyps, fourth and fifth decades of life for onset. Intermediate polyposis has hundreds of polyps, where the severe or profuse is the thousands, which is what most of us learned about in medical school and residency. Earlier onset. So the more polyps, the earlier it starts. That makes sense. There are some studies that correlate where in the genotype the mutation is and what the phenotype is going to be, but not all patients follow this exactly. Family history can be really powerful as well in terms of phenotype, and things like desmoid risk scores and everything take into account the family history just as much as they might the genetic mutation. Mutations at the 5' end and the 3' end of the gene and on a specific splice site on exon 9 are correlated with an attenuated phenotype. So the two ends and then this weird one in the middle. There are other mutations that predict a severe phenotype. And again, there's variation in this. And even within a family, there can be variation in how the FAP manifests. Attenuated FAP, some people say less than 100, some people say less than 30 polyps. Interestingly, this is primarily a right-sided phenomenon. It tends to occur later in life. This is the exception to the rule about risk-reducing surgery. The basic premise is that the polyps can be controlled endoscopically and the patient commits to surveillance. There's a possibility that they don't actually need their colon out. And this is just a good example of having to think really carefully, potentially scoping your own patients or making sure you know exactly what there was. Some of the recommendations about screening family members for FAP involve a flex sig earlier in life and then a colonoscopy once they develop polyposis. For families with a more attenuated phenotype, though, because this is more of a right-sided problem, full colonoscopies starting earlier, sort of around age 10 for FAP. There are really two surgical options once you start talking about surgery for FAP. Obviously, if you can control them endoscopically, you don't have to. You can do a total abdominal colectomy with an ileorectal, which is a relatively straightforward procedure, good functional outcomes, decreased rates of complication and reoperation compared with restorative proctocolectomy. The other option, as you know, is restorative proctocolectomy with or without reconstruction. You have to think about cancer risk when you do this, though. Some of the earlier data about FAP, and these are huge registries and sort of historic literature, was before we knew about genotypes and before we had circular staplers, so there weren't pouches, so IRAs were much more frequent, and the risk of secondary proctectomy was much higher because we weren't selecting patients for pouches. It was a choice between an ileorectal and an ileostomy. So as things got more severe, the risk of needing a proctectomy obviously increased, as did the risk of rectal cancer. That makes sense. So how do we select? And we're selecting based on cancer risk, primarily balanced with functional outcomes. We think about the risk of neoplasia in the pouch. Cancer in the pouch is rare, But the cumulative risk of developing an adenoma in the pouch at 10 years for a patient with classic FAP is probably about 42%. The cancer risk is less than 1%. And most carcinomas develop either at the anastomosis or in the rectal cuff, which means that some people will advocate for doing a mucosectomy for patients when you're doing a proctocolectomy. Some of the management options are endoscopic polypectomy or transanal excision, but ultimately, if they have uncontrolled polyposis in the pouch or a cancer, they need to be treated and the pouch may have to come out. Any questions so far? Okay. This is a decision analysis that kind of looked at quality of life years and came down on the side of ileorectal anastomosis from a quality of life perspective. The takeaway that you want from this is that if they have less than 30 polyps in their rectum, if they can be endoscopically cleared and they're interested, in ileorectal is an appropriate procedure for them. If any of those are not true, you should really consider doing a pouch. One of the surgical considerations for FAP patients are desmoid tumors. 1 in 6 FAP patients will develop desmoids after surgery. These are thought of frequently as like true masses, but there's also this desmogenic plaque that patients can form, which is relevant in surgery, especially if you're going to have to go back to someone's belly when they have that, because it can really affect the length of the mesentery. Surgical trauma is a major risk factor for desmoids, but these patients almost all have to have surgery. So there's a lot of questions about how can we predict who does this? How can we predict who needs this? And what do we do about it? Now that we do risk-reducing surgery for FAP patients, desmoids are a significant cause of morbidity and mortality for that matter. Even though they're not technically malignant, they can erode. They can affect blood vessels, they can cause obstructions, and they can be really difficult to deal with, especially if they're at the root of the mesentery. So surgery is the major risk factor. Other risk factors: female gender, family history, mutations at the 3' end of the gene. The type of surgery does not appear to influence desmoid tumor development. And there's a lovely paper that says young nulliparous women should undergo laparoscopic procedures. I would argue that everyone who can should undergo a laparoscopic procedure for risk-reducing surgery, or for any kind of proctocolectomy when it's feasible and safe and appropriate. It seems like laparoscopic surgery carries a lower risk of desmoids compared to open surgery, which probably has to do with gentle tissue handling, which is just something to keep in mind in general with both laparoscopy and open surgery, that being really gentle really counts here. The other question that some people have raised is whether doing a total abdominal colectomy with an ileorectal and then having to go back and do the pouch later would be difficult because of desmoids. In cases where that's been an issue, it does not seem like the theoretical risk of desmoids prevents patients from undergoing a pouch later. These procedures are happening in young patients, and particularly for women, fertility and fecundity is a big deal. So pelvic adhesions are a really significant concern. So again, some people say, we'll do an ileorectal for now and survey you, and then when you're done having kids, then we can go back and do your pouch. I don't actually know how frequently that's done, but it is something that's discussed. Laparoscopy reduces desmoid tumors. That's sort of the bottom line on this one. Took us till 2014 to prove it, but laparoscopic colon surgery is becoming more and more common, and hopefully all of you by the end of this year will be comfortable with this approach. So we're going to move on to some of the extracolonic manifestations. Thyroid cancer is an issue in FAP patients. The incidence is really not well described because it's primarily in a few registry studies where they start sending all patients for thyroid ultrasounds. So 1 to 12% is a pretty big range. The lifetime risk is probably about 12%. It tends to be more frequent in women and tends to be at a relatively young age. The outcomes are excellent, just like other thyroid cancers. Most thyroid cancers in FAP are just a regular, boring papillary thyroid cancer. However, again, on a standardized test, the cribiform morular variant should make you say FAP as a word association. Even though it's not the most frequent histology in FAP patients, it's associated with FAP and rarely found outside of it. Screening is thyroid ultrasounds, which is pretty straightforward, pretty low risk, not particularly invasive, but you want to think about this in the context of a patient who's undergoing a significant number of screening and surveillance procedures with a lot of anxiety. And every time we do a test on someone, we run the risk of finding something that requires follow-up that may not mean anything, which on a systems level is a big deal. and on an individual level, having ongoing, what is this? What does it mean? Needing additional testing actually can really affect quality of life and stress and anxiety levels amongst patients, which, as you might imagine, is an issue for some patients who have a genetic syndrome that predisposes to cancer. Gastric and duodenal lesions in FAP are the ones we think about, probably second most common after the colorectal ones. Funded gland polyps, which are sort of hematomatous. There is an increased risk of gastric cancer. However, the lifetime risk is less than 1% in FAP patients, but it is elevated relative to the general population. The good news is that we're recommending screening anyway of their duodenum, so that involves looking at the stomach. Duodenal adenomas in cancer are the second most frequent malignancy in FAP patients. About half are periampullary. The lifetime risk of duodenal cancer is 3 to 5%, which is pretty low. The mean age is sort of 40s to 50s. The recommendation is an EGD starting at age 25 to 30. I believe the official recommendation still says that they should use a side viewing scope. So this is something that requires an advanced endoscopist. But actually, our advanced endoscopists put a cap on their scope, and they're pretty comfortable with a regular scope using that technique, which is nice. Surveillance is based on findings. There's the Spiegelman staging of duodenal polyps that you can use to calculate how frequently you should scope them. It is a combination of size, histology, and number. This is just a summary of extracolonic malignancies and how to survey for them. So stomach and duodenum, thyroid, liver, and adrenal. The stomach we just covered in thyroid as well. The liver is a hepatoblastoma. It tends to occur in kids under age 5, which is a little bit tricky because you either have to screen all kids who are at risk for FAP, meaning they have a parent with FAP, or you have to do genetic testing very early in life, which is generally frowned upon. Usually genetic testing happens when it's clinically relevant or when they're 18, whichever comes first. So testing a baby who has no ability to make a choice, because not everyone wants genetic testing and diagnosis, and not every parent wants to know whether their kid has this throughout their entire childhood when there's nothing to do about it yet. But it would involve ultrasound and blood tests. And then adrenal ultrasounds, not particularly recommended because it's so rare. But these patients do best when they're sort of cared for in a multidisciplinary way by people who are making sure that they get what they need to get. And that's something to think about when you see patients with FAP. You're often going to be the person that knows the most about it and is the most interested. So you may end up personally coordinating their care unless someone else at your institution is willing to do it, or you have a registry or a system in place for this to happen. So take home points. Phenotype can vary. Not all patients will have a family history. Not all FAP patients need surgery. Other FAP patients should undergo risk-reducing surgery, and they need a lot of surveillance. I'm going to do a quick check on my time. Questions before we move on to Lynch syndrome? All right, I'm just going to keep going. Lynch syndrome is more common than FAP. 2 to 5% of colorectal cancer patient cases are related to Lynch syndrome, and the numbers are higher in cases under age 50. It's caused by a defect in the mismatch repair genes. The more frequent ones, MLH1, MSH2, MSH6, PMS2. There's also a somatic hypermethylation of the MSH2 gene called the EpCAM mutation that manifests basically essentially like Lynch syndrome, but is not actually a mismatch repair gene defect. About 1 in 370 people carry an MMR gene mutation, frequently associated with multiple polyps, early age of onset of colorectal cancer, and an accelerated adenoma to carcinoma syndrome. So I said at the beginning, we don't really call this HNPCC anymore, but still in the like 2010 to 2020 range, about a third of new references to Lynch syndrome, we're still calling it HNPCC. So we're all going to be experts, so we'll call it Lynch syndrome. Mismatch repair genes repair DNA synthesis, double-stranded DNA breaks, and are involved with apoptosis, recombination, and DNA stability. So when one of them is lost or defective, you have a decrease in all of those things and increased cell survival, which provides a selective growth advantage and a greater susceptibility to cancer. Most frequently, MLH1 is the protein and gene that are affected, but the others, MSH2 is the next most common. So we all learned about the family history and the Amsterdam criteria, sometimes known as the 3-2-1 rule. 3 relatives who have a diagnosis of cancer that fits the criteria. One is a first-degree relative of the other 2. At least 2 generations are affected, and at least one was diagnosed at 50 or earlier. So who's heard of this? You guys, none of you have your cameras on. You're killing me. All right, probably all of you have heard of this. Guess what? It doesn't really work that well. The sensitivity and specificity are both in the 50% range, but if someone has a good family history, it's actually probably useful. The sensitivity goes down when you have a more heterogeneous population. And one of the things to think about when you're taking family histories is small families, unknown histories, and then given widespread colonoscopies and other reasons that women have hysterectomies and other things, you can have phenotype attenuation. Some of the clinical features of Lynch syndrome-associated colorectal cancer, as we said, early age of onset. It's classically associated with right-sided colorectal cancer, but doesn't really follow the rules. There's plenty of non-right-sided colon cancers and plenty of rectal cancers in Lynch syndrome patients. Rapid progression of the adenoma carcinoma sequence, and that's because they're not following along the APC pathway. So 80% of colorectal cancers follow APC, more or less, and the rest are either mismatch repair or CpG island methylation pathways. The mismatch repair pathway happens more quickly. You can go from nothing to cancer in 1 to 2 years, as opposed to the 10 years that we really think about. The good news for these patients is that they seem to have stage for stage improved oncologic outcomes. They have a decreased response to 5-FU-based chemotherapy. We don't really know about oxaliplatin or irinotecan. Their response to radiation for rectal cancer seems similar, but they have the option of immunotherapy, not as a first-line drug still, but if someone were to develop recurrence and refractory disease to FOLFOX, they would be able to get immunotherapy, and they often have amazing outcomes with that, which is really nice. That's also true, by the way, for sporadic mismatch repair gene pathway cancers. So some of the histologic features, again, word association. Tumor infiltrating lymphocytes. Crohn's-like lymphocytic infiltrates, that's not confusing at all when you're talking about cancer, but sure. Tend to have poor differentiation, mucinous histology, signet ring cells. Those are all really scary kinds of things when you look at a pathology report, but in the context of a mismatch repair deficient tumor, it's a lot less scary. It's more expected. This medullary differentiation as well. So they're less likely to have positive lymph node disease or metastatic disease when compared by T stage as well. These patients have a real cancer risk, 80% lifetime risk for colorectal cancer for all comers with Lynch syndrome. It does vary a little bit by genotype, which we'll talk about. An MLH1 mutation is much more associated with colorectal cancer than an MSH2 mutation or an MSH6 mutation, and certainly more than a PMS2 mutation, which might have a much lower risk. The second most common cancer in Lynch syndrome patients is the 30 to 60% lifetime risk of endometrial cancer. And then there's a long list of other things. And again, you're taking care of a patient with Lynch syndrome, you have to think about all of this and who's going to be responsible for all of it. So one by one, we'll talk about endometrial and ovarian first. The risk is higher for patients who have MSH2 and MSH6 mutations. It can be anywhere from like 18 to 70%. Mean age at diagnosis is 46 to 54 years, which is pretty similar to the general population. Ovarian cancer, again, 7 to 24% lifetime risk. The screening is annual pelvic exam and endometrial biopsy by a gynecologist, at least by age 30. The role of transvaginal ultrasound and CA-125 is less clear. If you can, and if you're in a place that makes this happen, for your female Lynch syndrome patients, having the endometrial biopsies done at the time of colonoscopy is something that's well described and is great for patients, but difficult to coordinate. The recommendation is that women with Lynch syndrome have prophylactic risk-reducing surgery by age 40. And if you're operating on them for their colon, you should really consider it as well. We're going to get into the guidelines in a few minutes. Small bowel cancer is a real issue in Lynch syndrome too. It's extremely rare overall in the general population. Compared to the general population, the risk is higher for Lynch. The lifetime, so this range is big, right? Less than 1% to 7%. And that just tells you that it's hard to characterize because you have a lot of different registries, and within registries, you have families. So the phenotype in the family may sort of be outsized compared to other sort of non-registry patients. Tumors are evenly distributed throughout the small bowel, and there's no routine screening. It's hard to detect this before they're symptomatic unless you're doing scans and imaging for other reasons, which definitely can happen. You're doing your follow-up for your colon cancer and you see the small bowel cancer. Certainly better than them presenting obstructed. Gastric cancer. So this is an interesting one because when Lynch syndrome was first described, gastric cancer was thought to be a huge, prominent part of the syndrome. Then it sort of swung the other way and said, well, now that we treat H. pylori, maybe it's not, but certainly in other parts of the world, the rates of gastric cancer in Lynch patients is higher than it is in the US. The lifetime risk is 5 to 13%, and it's highest in the MSH2 deficient patients. Again, EGD, biopsy, surveillance every 2 to 3 years. They're getting colonoscopies anyway, so this isn't that complicated to coordinate most of the time. There's also a risk of hepatobiliary and pancreatic cancer. The lifetime risk, really rare still, but compared to the general population, high. The median age of diagnosis in their 50s. The lifetime risk of pancreatic cancer is 0.4 to 4%. There's no specific recommendation for screening. They're having a EGD. It's not recommended that they have ultrasounds or anything like that at the same time. It's not recommended that they have MRCPs. Just questionable what to do to detect these before they're symptomatic. Urologic cancers are another consideration. Urothelial cell carcinoma, not transitional cell carcinoma of the bladder, not renal cell carcinoma, but urothelial cell. And again, MSH2 to MSH6 mutations compared to MLH1, the risk is 20 times the general population. This is an easy one. They should have an annual urine analysis and cytology. When I see my patients with Lynch, I just order it. Some people think they should have a cystoscopy and a CT urogram. That's not supported by data. There's a questionable increased risk of regular bladder cancer, which, as you'll sort of start to see as I go through the less common ones, is again, like, is this an association or is this patients who have increased screening, we start finding things? This is true for breast and prostate cancer. The relative risk is higher. But again, it's not 100% sure if the mismatch repair genes are contributing to these cancers or if these are just patients who are getting more aggressive surveillance overall, and therefore we're finding things. Similar to my table on FAP, this is a surveillance for non-colonic malignancies in your Lynch patients. Skin exams annually for skin cancer, which we didn't really talk about, but is a thing. Gynecologic care, no recommendations for small bowel. For stomach and HPV cancers and EGD. For urologic cancers, urinalysis and cytology. So how do we diagnose Lynch syndrome? There's 2 options for tumor-based testing, and this was sort of one of my interests when I did research, so bear with me. Microsatellite instability is a PCR-based test of short repetitive nucleotides. They use 5 microsatellites that they're testing for, which is pretty much equivalent if they had used 10. PCR is straightforward. It uses a small amount of tumor-based tissue, but it does require additional testing outside of the realm of like your usual pathology lab, but it's still pretty widely available at most places. The other option is immunohistochemistry for mismatched repair proteins. So they stain tumor tissue for proteins produced by the MMR gene and look for the absence of uptake using antibodies. There's really high concordance between testing. So why might you choose one versus the other? So PCR historically was more expensive. IHC required 4 additional slides of cancer. Both of these are much more accurate on cancer compared to even adenomas or advanced adenomas. The other thing that used to be really important was if you did IHC, you would then know which gene to test for when you went for genetic testing. Whereas MSI didn't tell you that. And now we just send everyone for panels, so who cares? However, this should be getting done on your biopsies whenever feasible. There are 2 things to know about this. In every place that I've ever worked, the IHC staining comes back as an addendum to the path report. So if you get this patient in quickly from their gastroenterologist, they may have a diagnosis of cancer, but you got to remember to go back and look at their staining. And remember, 50% of patients with Lynch syndrome don't have a family history necessarily. That's going to make you think of it. The other thing that I'll say is that people use MSI and IHC interchangeably, including like the path reports at my institution. They do immunohistochemistry and then they call the tumors microsatellite stable, which makes me a little nuts, but I think is probably actually okay. So most tumors that are MSI high actually are sporadic. They're not related to Lynch syndrome. 20% of colorectal cancers demonstrate microsatellite instability. This is caused by a somatic hypermethylation of the promoter region of MLH1. So the tumor acts like a Lynch syndrome tumor, but the patient does not have Lynch syndrome. Places that do immunohistochemistry, if they have absence staining for MLH1, they do a reflex test for a specific BRAF mutation that accounts for all of these. So 85% of the absent MLH1s are going to be sporadic. This tends to occur in older people. So if you look at the distribution of microsatellite unstable tumors, you're going to have a bump at the low end caused by the Lynch patients and a bump at the high end caused by the sporadic patients. Screening is great. I think it is much more widespread in the last 10 years where biopsies are being routinely tested for Lynch, and we're finding cases of it that wouldn't have otherwise been diagnosed. So this is sort of the outcomes of Ohio State, New Zealand, Australia registry, and then at Sloan Kettering as well, which was an age-based program. They originally were doing it only on tumors in patients under age 50, and now they do it on everyone. I don't know if anyone is at a place that doesn't do this at all unless you request it, but most places are doing it right now. So why should we test? I've said 4 times, I think, that we should test before we operate on them. Because the amount of surgery you do can change. No one's recommending that you go back and do more in a patient if you diagnose them with Lynch postoperatively. But if you diagnose them preoperatively, you can have that conversation about subtotal colectomy for colon cancer to decrease the risk of metachronous cancers or advanced polyps. You can also talk to your patients about whether or not they should have prophylactic gynecologic surgery. And then you can make sure they get appropriate screening for other cancers, and there's benefits for at-risk family members. Trying to diagnose someone before you take them to the OR requires coordination and a little bit of extra effort for all of us. If you see someone in the clinic who has a cancer and you're concerned they could have Lynch syndrome, they likely need to be referred to genetics and then have blood drawn, and it can take a couple weeks. They can rush it if you ask, but it does delay things. But if the patient's not obstructed and they're not bleeding, maybe a few weeks to do it right is worth it. Certainly, you don't want to then scope your patients a couple years later and have another cancer and have to go back, both for their benefit and your own. Segmental versus total abdominal for Lynch syndrome has been studied in just a few papers. After segmental resection, the rate of metachronous adenoma is 33% compared to 11% for a total abdominal carcinoma ranging about a quarter of patients. And then if they do a total abdominal it's up to 0 to 8%, but we're looking at 2 studies here. We're talking about total abdominal not proctocolectomies. From a quality of life and a surgical risk perspective, the recommendation for colon cancer in Lynch patients is to do a colectomy, not a proctocolectomy. If they have rectal cancer, the official recommendation is to individualize treatment. Meaning have the conversation, do what's right for your patient, do what you and they decide together, but don't prophylactically take out people's rectums just because you're worried. The ileorectals are relatively easy to survey later. So prophylactic gynecologic surgery, things to consider. How old is the patient? Are they done having children? What's their family history and what's their genotype? So the general population has about a 1.7% lifetime risk of GYN cancer, of endometrial cancer. Mismatch repair mutation carriers have almost a 40% risk, 30% on MLH1, 44% on MSH2. Definitely worth the conversation. You're operating on them anyway. EpCAM, Lynch-like syndrome. So this is a germline hypermethylation, whereas the BRAF mutation we talked about with MLH1 was a somatic hypermethylation. This is a germline one. So they function essentially like an MSH2 mutation carrier. One of the things that can happen is you have a patient has a slam dunk family history. You're like, I'm sure this patient has Lynch syndrome, but they go to genetics and they're like, we can't find anything. That is a real syndrome without a name. The cancers in this syndrome tend to be more likely left-sided. They're better differentiated. They're microsatellite stable. The extraclonic tumor spectrum appears to be limited. This probably represents a range of gene mutations that we haven't quite figured out yet. And I think over time, as we name more and more syndromes with small numbers of patients, this will become less frequent. It's hard to know what to do with these patients because clearly they have something, and it's hard to know what to tell their family members. But you just have to treat them based on their phenotype and be more aggressive with screening for everyone else. So the most current guidelines, so this is from the ASCRS practice parameters. After the diagnosis of colorectal cancer, total abdominal colectomy is preferred. Segmental resection should be considered because of functional outcomes. Again, individualize your treatment. Patient-centered care is it. Annual colonoscopy, once a year. In the setting of rectal cancer, you should do what you need to do in terms of neoadjuvant therapy, and then make a decision about what to do next. Even more than the regular rectal cancer patient, if they're going to need radiation, they should have it preoperatively. Please don't radiate your pouches. And then women should have THBSO if they're going to have surgery anyway. If you're seeing a patient who has a family history and a personal history of Lynch syndrome, but doesn't have colon cancer, they still should have prophylactic surgery for their gynecologic organs, even if they're not going to for their colon. That is to say, they should not have preventative surgery for colorectal cancer. You should wait either until they have an unresectable polyp or cancer, because not all of them will. It's not like FAP where it used to be almost universally fatal. This is a much more manageable syndrome without prophylactic surgery. Any questions? Okay, we're going to see how much we can get through in the last 20 minutes. MYH-associated polyposis is an autosomal recessive genetic syndrome. Carrier frequency in North America is about 2%. Variable penetrance. If you looked at patients who had polyposis but negative FAP testing, the prevalence varies. Colorectal cancer tends to be later onset. The extraclonic tumor spectrum is not as well defined. This is a syndrome where there are specific founder mutations in specific populations. So there are certain ethnicities where this is more common. Genetic testing. So anyone with cancer diagnosed under 40 should be having genetic testing anyway. More than 10 adenomatous polyps in the absence of an APC mutation and a family history that looks like this. Again, you don't know until you ask. Don't take the word of the chart, except for if it's been done by someone who's a geneticist on what the family history is. Just do it yourself. And again, now we send everyone for multi-gene panel testing, so it doesn't really matter. This other stuff, we test them. Some of the extraclonic manifestations that have been described, so gastroduodenal lesions, including cancers, ovarian, bladder, skin. We don't know what to make of this because some of these occur in the general population and may be unrelated. So it's hard to know what to do to screen and survey these patients. There's also an increased risk with being a carrier of the MYH mutation. It's about 2% in British and North American populations, 1 to 2% of colorectal cancer patients, but the odds ratio of colorectal cancer in someone who has one aberrant copy of the MYH gene is an odds ratio between 1.15 and 2 times the general population, which is not nothing. All right, now we're on to rare syndromes that get less than a paragraph in a textbook, but at least you've heard of them now. The POLD1 mutation is a polymerase proofreading associated polyposis. This is autosomal dominant and highly penetrant. Colorectal cancer, as with the other syndromes, duodenal adenomas, brain tumors, endometrial cancer, maybe breast tumors, we're not really sure. NHTL1 associated polyposis, which is really rare and the phenotype's not really defined. And then the GREM1 or CRAC1 mutation is a mixed polyposis described in Ashkenazi families, serrated adenomatous and hematomatous polyps, and no extracolonic features have been described in these families yet. We're finding new syndromes because it's so much easier to do sort of high throughput genetic testing and sequencing. And you can take a cluster of people in a family who have the phenotype and compare them to the other people in the family who don't have it. It does take time to confirm that mutations are pathogenic. So this is a rapidly evolving area. I had a patient who came to me actually after his surgery. I was like, oh, my cousin told me I had this thing. And I was like, I tried to figure out what he was talking about. And he finally, brought his cousin's genetic testing and he had a CRAC1 mutation. So that was fun. So then there's the patients who you just can't find a syndrome. And you're like, how is this possible? You clearly have something. They have what's called uninformative genetic testing. And if you read the notes from the genetics people, they say you should come back and get retested in however long their protocol is. And you're like, well, why? Because even with the most current testing methods, not all mutations can be identified right now. For these patients, we don't know their extracolonic manifestation risk. We do know that their families are likely at increased risk. We recommend early screening, though there is a chance that we're overtreating. And just like what I was talking about with the thyroid imaging for FAP, you're subjecting people to a lot of testing. You may find things that need to be acted on that maybe are not actually clinically significant, but the risk of missing something is really needs to be balanced against that. And the management of these patients are going to be based on phenotype. All right. I'm going to try to run through some non-adenomatous syndromes just so you've heard it and seen it somewhere. We're going to talk about Peutz-Jeghers, juvenile polyposis, the P10 syndromes, and then hyperplastic polyposis syndrome, which is also called serrated polyposis syndrome at this point, and then hereditary mixed polyposis. So Peutz-Jeghers is an autosomal dominant mutation with a mutation in STK or LKB1. You've probably heard about the mucocutaneous pigmentation, sort of mucosal changes, and also on the palms and soles. You may not have heard those fade with age, so adults with Peutz-Jeghers may not have them anymore. GI tract polyps and GI and non-GI cancer. So classically, this is a hamartomatous polyposis syndrome. So branching smooth muscle bundles in the biopsy is the key word here. You guys are all taking the car site soon, right? This might be useful. So the distribution of their mucocutaneous pigmentation, lips or perioral, hands, buccal, feet, and they develop early on and tend to go away later. These pictures are some adults and some kids. Polyp location. So this is a talk about colorectal cancer, but the polyps in Peutz-Jeghers are more frequently in the small bowel. They may occur in more than one location, of course, and they can cause intussusceptions, they can bleed, they can cause obstructions. We do genetic testing. 50% of them don't have a family history or a family mutation. They have a really high risk of cancer. Colorectal cancer is the second or third most common, but these patients are really high risk. They should have EGD, colonoscopy, small bowel series, or double balloon endoscopy. I think there are people who've done combined sort of the equivalent of a push enteroscopy with laparoscopy, where the laparoscopist is feeding the small bowel over the scope to do polypectomies, which is pretty neat. They need pancreatic cancer screening, breast screening, of course, GYN, and then testicular cancer screening as well. So again, this is a problem that tends to affect children more than some of the other syndromes we talked about. And you don't want to forget about the psychological impact this has on patients and parents and families as well. Juvenile polyposis, which, PJS, JPS, fine, they're both hamartomatous. That's a nice way to remember them. This is a clinical diagnosis in most patients. More than 5 juvenile polyps throughout the GI tract. Any number of polyps, though, in a patient who has a family history, you don't have to wait till they develop 5. Again, they can be anemic, they can bleed. These can have malignant degeneration into an adenocarcinoma. Risk of colon cancer over the course of the lifetime, 39 to 68%. Gastric cancer, about 21%. And this is sometimes associated with other anomalies, macrocephaly and hydrocephalus, some congenital heart disease, and then undescended testicles and renal agenesis are also associated with JPS. This is autosomal dominant, but the vast majority of cases don't have a family history. There is more than one gene associated with JPS, so it's a spectrum. And again, they need EGD colonoscopy at least by age 15, or when there's symptoms, can be repeated every 3 years. And then you really just want to remove all the polyps. If the polyps in the colon are unmanageable endoscopically, that's when you start thinking about a colectomy. Cronkite Canada syndrome is in several textbook chapters about hereditary cancer syndromes. It's not hereditary, but it does involve a generalized GI polyposis and severe protein losing enteropathy, dermal pigmentation, and atrophy of the nail bed. So it sort of like looks like it could be a genetic syndrome, but it's not. Right, the P10 syndromes. So Cowden syndrome, which most of you have heard of in relation to breast cancer, and then BRRS, which I'm not even going to try to pronounce. These are autosomal dominant mutations in the P10 gene, more hamartomatous stuff. They have a variety of other tumors as well as skin manifestations. They may have macrocephaly and mental impairments. Colorectal cancer is rare, but not zero. P10 syndromes obviously are associated with a global risk of cancer, and the colon is not spared of any of that. Hereditary mixed polyposis syndrome we talked about in the rare syndrome, so I'm just going to skip. And let's talk briefly about serrated polyposis syndrome. Serrated polyposis syndrome comes from meeting the World Health Organization criteria because there's no genetic mutation that we've identified yet. Patients who meet the criteria have more than 30 small hyperplastic polyps throughout the colon, or more than 5 proximal to the sigmoid, and at least 2 are more than 1 centimeter. So you're all doing endoscopies, you're seeing these tiny little hyperplastic polyps in the rectum that we don't even necessarily biopsy anymore. That's not this. Generally, it's patients who have large numbers of serrated polyps in the more proximal colon. But when someone actually meets the criteria, their cancer risk is high, 37 to 70%. And patients may have a mix of hyperplastic and serrated histology on their biopsies. The larger lesions will demonstrate BRAF mutations and extensive DNA methylation. This can be familial, but again, we're still working this one out. This is what a serrated polyp looks like. You hear sawtoothed pattern to the mucosa or the upper crypts, and then the lower crypts are all distorted too. All right. It is 7:51, and that is everything I had prepared for you. I wanted to leave some time for questions. So thanks very much for having me. This was lots of fun.
For the serrated polyps, they don't necessarily do DNA testing or genetic testing on the polyps, right?
No. I mean, this is rare.
Unless they're like really large.
Yeah, and I think if you saw someone who had 10 sessile serrated adenomas, you'd start really wondering what to do about that, because as you know, those are probably higher risk polyps than tubulovillous adenomas. And if someone has that many, especially because they're so hard to survey at times, they are more likely to be flat and hard to see and have a little mucus cap on them. I get clinical judgment here because it's all about the phenotype.
Yeah.
So some of you already heard about the survey that I'm doing. We're still going to do questions if you want. I am trying to capture your experience at the beginning and end of fellowship about pouch education. You may have gotten an email through your program director, or if you were on last time I came on to plug this. This is a survey. It'll take you 5 minutes. I would be so appreciative. And you are all important current and future stakeholders in this project in terms of how we're going to teach pouch surgery. So think about doing the survey, please.
Can you put that link in the chat for us?
Yeah, I was just going to say the same.
Oh, yeah. Sorry. Yes, I in fact can. That was really silly of me. I should have put the QR code instead.
You are so fancy.
I'm becoming a REDCap expert slowly and painfully. But REDCap will make QR codes for you. It's easy.
Love it.
My other piece of advice, since I started with a piece of advice, my other piece of advice is that no one has ever complained about a talk ending a few minutes early. Jonathan's smiling at least. All right. Well, I'll stay on for a few more minutes in case anybody has any questions. But that's it. Have a good night. Thanks again.
Thanks so much for joining us this Sunday evening. We really appreciate all of this condensed info.
Yeah, it's a lot in a short amount of time. This is the condensed version of the talk too.
And for all of our guests, don't forget to follow us on Twitter if you're not doing that yet. We're at CRS Virtual ED.
Thank you again.
Not a single question other than you. I can't believe it.
So is the survey supposed to be for past fellows as well?
No, so I'm doing it now and then in the spring again. The survey right now is like it's sort of like a spin-off on the Simple app, like rate yourself in these categories right now and sort of what do fellows think they need now, and then we'll do what they think they need at the end of the year again.
Got it. Okay. I try to fill it out and
Thank
then
you.
kick me out.
Well, thank you for trying. I have 30 some odd responses, which is not quite a third of colorectal fellows, but considering that I couldn't actually email it directly to fellows, it's a reasonable response rate, but considering how interested people should be, it's like kind of crummy. But it requires program directors to forward it because there's no centralized email listing of colorectal fellows. Interesting.
But there's one of program directors.
Right. So APD CRS was able to send it to all of the program directors, but not all of them are going to forward it. So it's a two-step thing.
I guess since we're here, I wanted to ask you, I emailed Dr. Goldstone. I haven't heard back. It's been a couple of weeks. Is this normal? Should I reach out again?
Yes. And I will, why don't you CC me on it actually?
Okay. Yeah. I mentioned your name casually.
And CC me. I'll talk to him.
Okay. Sounds good. We'd love to have him on at some point. So.
Yeah, if he can't do it for some reason, I can do that topic too, like in the second half of the year.
Okay.
I have something somewhere about it. He's just kind of like the person, and I think it's neat when you can have that. This is what he lives and breathes. Whereas, like, I make jokes about being the anal dysplasia queen, but that's not actually a title I want. Anyway,
fair enough.
It's great to see you.
Likewise. Thanks for coming on. There's my kitchen.
It's nice.
Thanks. Yeah, I got a new fridge and it fit perfectly.
I was gonna say it looks like I'm like looking at your fridge and I'm like, ooh, it has drawers.
It was on sale, so.
Got it. Okay, cool. I will see you later.
All right. Have a good night.
You too.